was most recently the CEO. I retired in November, and so I'm filling my time with really important things like this. So glad to be here this morning.
Thanks
Yeah.
for picking up the torch too, Kelly.
Yeah.
Jeanette Graves. And I do a lot of work on youth mental health access to care in rural communities around the country. And also I live in northeastern Washington state. So um, deal with these problems in real time all the time. But thank you. I did push record, everybody, too, just so you're aware.
Do you want me to go next? So I'm Rob Ross. I'm a family physician, but I've basically spent 3/4 of my career in academic medicine and was the champion for starting 2 residency programs and deeply involved in the rural program in Klamath Falls and started a RTP in Madras over the last 3 years. But my institution, I think 5 years ago, basically promised to start innumerable numbers of residency, up to 110 residents, and backed out because of various very poor uh, institutional decisions about funding and things. Anyway, I want to talk about behavioral health because I think everyone that I know, and this is including social workers, psychologists, family doctors, internists, trauma surgeons, the biggest hole in the healthcare system is the recidivism of patients through their behavioral health and activities coming back for more care. And one of the biggest problems with completing the circle of mental health care is that to a person, these providers and social workers and psychologists all express the fact there is no access to psychiatric services in Central Oregon, basically, or very limited access. There's no access for, especially the seriously mentally ill, if they have Medicare or Medicaid or no insurance. They have no resources to send them to. And essentially, I spent the last 2 years of my career getting $500,000 from a local grant, an earmark from Ron Wyden with lobbying of $1.2 million. So we started with $1.7 million. Promise of indenture from OHSU to be the educational sponsor for another few $1 million. And we had approval from the ACGME for a full 3-year residency program, and we're well on our way. And the institution backed out again for very dumb reasons and redirected the money, probably illegally, and certainly not what the community needs towards having a telepsychiatry service here, which is not what the community needs. Anyway, it's just unbelievable the number of forces working against improving the healthcare workforce. And I'm particularly worried about psychiatry because people here in the youth, our catchment area is big. You know, I've seen youth sitting in the emergency department waiting for beds and services for 6 weeks. Like, that's not good for your mental health. And our opportunity was totally squandered. And they'll never have another one like it where they've had more funding than they could have got anywhere else and a champion, right? So I think that psychiatric care, Oregon is probably between number 49 and 50 in access to psychiatric care nationally, because I did all the research. And the monies need to be spent on behavioral health here, and particularly psychiatry, because without having access to consultations, it's very hard to practice as a, peer support, social worker, LCSW, family physician, whoever you want. And that was the interest in joining. So sorry for the long intro, but as you can tell, I'm a little agitated about this whole situation.
Shall we go to Samantha?
Hi, I'm Samantha Pollock. I'm a research scientist working on this project at the University of Washington, Center for Health Workforce Studies. I'll just be here taking notes today. And I actually grew up outside of Portland. I'm from Beaverton, so I'm happy to work on some Oregon research. Thanks for having me.
Thanks, Samantha. And forgive me if I don't pronounce this wrong. Surya?
Yes, that's correct. I'm Surya Karlapati. I'm a psychiatrist. I'm both certified in adult or general psychiatry and addiction medicine. I work at the Oregon State Hospital. This is my 9th year. So I've been in the system, seen a lot of things. Actually, I've seen some positive changes as well. I don't want to add more than what Dr. Ross has already mentioned. There's a lot of work to be done. He called recidivism, we call the revolving door, pretty much it's all the same. But what he sees is totally opposite to what I see, because 100% of my practice is inpatient. So we see our patients, there's really a good chunk of resources being allocated to the state hospital. That's where I work. And we see some wonderful things happen with our patients. And then they go out and just in a nutshell, whatever Dr. Ross has mentioned, the reintegration, the maintenance, the continuation or remission or whatever sustained remission or just that continuation of that balance is missing, and they come back in less than a few months. So we're not seeing the progression being maintained, and there could be tons of reasons that we all know, and we can debate a lot about it. There should be some policy changes needs to be bring in some budget allocations, addressing workforce shortage. I trained in Mississippi, and I'm surprised actually Mississippi ranks better than Oregon in terms of mental health. As Dr. Ross said, like maybe it's 49, 50 Oregon. We have more residencies in psychiatry than Oregon, and I'm totally surprised. That's definitely an area where we need to, there should be a focus. I believe there is only one residency program in the entire state of Oregon through HSU for psychiatry.
There's actually two. There's
For
one in,
psychiatry?
yeah, I think they're expanding to 8 in OHSU, and there's one in Corvallis, which has
That's
4 or 5.
AOA, right? Is
Yeah.
that now that
They both have to be certified by the ACGME though, right? So they've come together with the same standards basically. So
that's right.
yeah.
It's still, we need more position.
It's still pathetic. I thought family medicine was the worst, but my friends in psychiatry, I feel very sorry for them.
So there's definitely a lot of work to be done.
Yeah.
So that's why I joined this committee, and I've seen some really good things that's happening outside. I'm also the current Oregon Psychiatric Physician Association acting president. So we've been working from the legislative side to bring some policy changes, especially addressing the significant concern that Dr. Ross mentioned, like these young and adolescent patients being stuck in the EDs. We don't have any child or adolescent beds in the state of Oregon, at least not at the state hospital. Even though we are like a 600-bedded hospital, we don't have a single child or adolescent bed. So
Right.
there's a lot of work to be done.
I agree.
Thank you.
Thanks.
Thank you, Surya. How about Dr. Hemmings? Just a quick introduction.
Yes, hi, I'm Dr. Hemmings. I own a group mental health practice in Beaverton. Particularly concerning right now is, as it relates to the healthcare workforce, is in one, recruiting and retaining mental health providers here in the state of Oregon. There are competing forces, and I can't really put my finger on it, with larger, I don't even call them venture capitalists, but larger mental health, behavioral organizations that, as a small group practice, we're competing with for staffing. And, it's really hard to stay competitive. And, you have the local community-based mental health organizations here where honestly, clinicians don't necessarily want to work with because the caseloads are so high, right? So just in terms of thinking about the mental health workforce, I think we need to also look at organizations and companies that are coming in from outside of the state. Thank you.
Great point. That's the terrible corporatization of medicine where all you look at is the balance sheets and not the patients. It's happening to everyone.
Yep.
Thank you, Dr. Hemmings. How about Mike? Would you like to introduce yourself, please?
Yeah, hi. My name is Mike Norman. So I work with the Higher Education Coordinating Commission, and specifically, I'm in the Office of Workforce Investments, and even more specifically in the Youth Works team. So I'm mostly here to listen and just, hear about from like the workforce perspective. But additionally, um, our office is piloting the Mental Health Youth Corps program in Oregon, and really it's a program to establish and create pathways for transitional age youth to start entering into the healthcare workforce and behavioral health specifically. So pilots include partnering with community colleges and other training institutions to create those pathways. So here to listen in from that perspective, and thanks for all your knowledge and hard work.
Thank you so much, Mike. As a longtime teacher at Temecula Community College, I appreciate what you're doing there.
Yay.
All right, Summer.
Hi, everyone. My name is Sumner Brooks. I'm calling in from West Lynn. I'm a public health dietitian, and for about the last decade, I've been focused mostly on professional continuing education and training, specifically in eating disorder care. And right now, I'm here with Eating Disorder Provider Education Network, which is a national nonprofit. And our give back mission is to provide free training to providers in rural and underserved communities. There is very, very little eating disorder care accessible. And the more the more at need, the more food insecure you become, actually your risks of eating disorders increase. But even right within all of our communities, there's very little access to eating disorder care, very low detection rates. So my colleague, Katie Grubiak, she's actually in the primary care group right now. We're working on ways to provide training to primary care level providers, but providers in the mental health, medicine, and nutrition realms to help tackle this issue for people of all ages. But specifically, when you look, kind of zoom out at the eating disorder issue, the earlier you can intervene, the sooner we can detect that someone has an issue. You can see just enormous differences in terms of the impact on the person's long-term physical and mental health, but also on the economic costs that come with this huge public health issue that is really left unaddressed. And we see these amazing mental health initiatives that are popping up so much more frequently now, and nowhere are eating disorders really mentioned or visible at all. So we would love to see how we can bring eating disorder awareness into this already really developing area of mental health awareness. It needs to be there. and, fighting against the stigma and the misinformation and all of the sort of outdated information about eating disorders is making it harder for people to get care. So in the last few years, we've been able to train over 600 dietitians in about a 12-hour course virtually to be able to guide a family through what we call home-based care, which eliminates the need for people to go to residential centers. They can't afford them. There's no insurance coverage, all of that thing. So we really have this foundation of how we can take this model and train all different healthcare providers actually very quickly to have a huge impact in being able to help people right in their own communities, right where they are, using their family resources and their community resources to kind of move from this dysfunctional system of having somebody to have to go somewhere to get treatment for an eating disorder. So that's what I'm here for.
Thank you so much, Sumner. That sounds very powerful. I mean, the eating disorder is likely to be occurring in people's homes, and so treating them in their homes and communities seems like it would be most effective. So we've got two more. We have Meredith and then Tim.
Hi everyone. Good morning. My name is Meredith Howling. Pronouns are she, her. I'm a research analyst with OHA's Healthcare Workforce Reporting Program. So I'm just here mostly to listen and to kind of try to think about what data we have that could answer the questions that come up. And I'm located in La Grande, so I am a rural Oregonian as well.
Thanks, Meredith. Tim, looks like you're also with OHA.
Yes, that's true. Hi, Kelly, and hi, everyone. Nice to see some familiar faces, hear some familiar voices. So I'm Tim Nesbitt. I'm the Behavioral Health Workforce Incentives Manager with the Behavioral Health Division at OHA. So what my team does is we, for the most part, we work on grants to provide incentives for the behavioral health workforce. The team came out of the pandemic, and so still pretty new, but certainly getting some experience since then. And I'm also a licensed professional counselor. Had a little over a decade in the field before working for OHA, and working in mobile crisis, rural mental health, and domestic violence treatment. So happy to be here.
Thank you so much, Tim. If it's all right, Jess, I just want to add, I've been attending the House Behavioral Health Committee at the legislature at the Capitol the last couple of weeks, and there are definitely some legislative initiatives that have the potential of increasing behavioral health access here in Oregon. So if you'd like to connect with me outside of this meeting via email or something, I'd be happy to send you the names of those bills and what they're hoping to accomplish.
Perfect. Thank you. So we have a handful of questions that we previewed in the main session, or the main kind of group. There's some related to the previous report and then some related to the theme. I'm going to put them all in the chat. And if you have reviewed the previous report, we could start there. That was also sent out at the beginning. I can also post that. I think I can post it in the chat. Maybe not. Because I don't know if I can add a link. But these are the questions. So the questions related to the previous report, we're interested in what worked well that we should keep. What should we expand or add? What should we take out? Thank you, Kelly. And then what was important for us to know as we move forward, specifically related to building off of the previous report. And then the rest of the questions are around this behavioral health theme in particular, and we've already talked about some of these pressing workforce issues, data, and then data sources that could be used, and reports and other materials that we shouldn't miss, sort of things to make sure we keep in mind. So, I feel like people could just shoot. I know that folks have a lot to say and a lot of opinions. And so I'm frantically typing, and I know Sam is too, to try to incorporate as much as possible into our outline and report. So we
I
could
just
just,
want to highlight and I don't remember the year, I apologize, but the behavioral health rates for Medicaid were increased significantly several years ago. And it ended up creating a problem because more and more people started taking on Oregon Health Plan clients, and the coordinated care organizations here, budgets were blown because their folks that were Oregon Health Plan members were accessing behavioral health at a much higher rate. And as a result, this year, our options counseling and other agencies took a cut in what the coordinated care organizations are offering us for behavioral health care reimbursement. So that's just a reality in the landscape right now.
Yeah. Well, that is a reflection of not having a healthcare system that is coordinated. I mean, it isn't a system, right? It's all these little pieces of service and CCOs and a completely divided patient pool, which means you have no access to this. I mean, these problems are only solvable at the federal level, I think. But so we can play around and try and certainly talk about that. I thought that was a really good thing, working to get the rates higher for absolutely. But of course, those secondary outcomes don't always, but are not always anticipated, are they?
did we have the workforce to handle an influx like that of Oregon Health Plan clients?
Well, that was part of the problem. It certainly didn't have as many therapists as might have been needed. But on the other hand, it still blew the budgets of the CCOs for the mental health services that were provided.
I know there was a Medicare change recently, relatively recently in the last couple of years, around reimbursement for MFTs and mental health counselors. Has that changed anything, or is there anything that would be helpful, important to know around that?
I think one of the things that it changed, Janessa, was they also started allowing unlicensed providers that were not affiliated with the coordinated care organization to bill Medicaid. And so these are folks that are straight out of graduate school that are not being supervised inside of an agency. And so that helped with the problem of access. But also, it's just interesting to me that the very newest mental health providers straight out of graduate school are working with the folks in this case with the highest barriers and the most severe mental health issues at often.
Yeah.
So,
Oh, that's a great point, because you know, education done properly with proper certification and supervision does everyone good, because you can take these wonderful graduates, many of them, and put them in an educational situation. It's true across all jobs in the healthcare industry, right? And you can increase your access and still maintain the quality. And it's so interrelated that I didn't know that had happened. I didn't, we were just happy that our rates went up for our LCSWs and PsyDs and those people who were in the clinics in, supportive, well, not supportive roles. I mean, they play a huge role in the clinics, but that's interesting. I didn't know that.
Dr. Hemmings, you have your hand raised.
Yeah, I just want to clarify something about the statement that was just made regarding quote unquote unlicensed. So just speaking for social work practice, someone who is, these individuals are actually under supervision, right, as CSWAs. They're not fully licensed to practice independently, but they are under supervision, clinical supervision, as is required by the board. However, as a CSWA, you're not allowed to practice independently, right? Which is, I think, where some of the issues arise. And, is it lack of board oversight, that created this issue, a misunderstanding of what the rules are? But I just want to clarify that these individuals are under supervision, that even though they're not necessarily affiliated with an agency. And I think a few years ago, I reached out to the board to clarify, because it wasn't really clear what they meant by agency, right? So, for example, if I'm a new grad and I have received approval by the board to be under supervision and I form an LLC, is that LLC considered an agency, right? Because the board rules say you have to be employed, by an agency. And the board at the time said they had never really been asked that question. So a lot of this issue around quote unquote unlicensed professional, I think also goes back to some of the lack of clarity from the boards of licensure. I don't like the term unlicensed because they are licensed, they're just not licensed to practice independently. And how you define independent really is up to the board's, interpretation. So just want to clarify that.
That's a very helpful clarification.
And
And I want to recognize that Dr. Carla Potty has his hand up, and we have very limited time available.
Yeah, I just want to add, is there any data that this newly graduating workforce, is there any decrease in the quality of care? I know we touched different topics, but is there any data if there is any reduction in the quality of care that they deliver? Would something also would help to capture?
That's a
Sorry.
very good question, one that I asked when the state moved to remove these individuals from being able to practice, and I never got an answer to that.
Okay, so that's a question about training, and we can look into data around quality of care as well.
and definitions of supervision. That's so important.
Okay.